I feel a little bit like Jay Chablani after following several excellent talks of what can I do just a little bit differently and talk about things that have not been touched upon over the course of the past hour. So this talk is entitled The Evolving Story of Fluid in the Treatment of Neovascular Age-Related Macular Degeneration and What Lessons We've Learned. So when we started off with our anti-VEGF therapy for all of our cardiovascular diseases, we saw something we'd never seen before with laser or other modalities that we had available to us. We got that very fast improvement in visual acuity, that very quick drying, and many people referred to it as the wow effect. But on closer inspection, we found that those are averages. When we look at them on a patient-by-patient basis, we had significant variability and very low correlation coefficients between visual acuity improvement and CST, and that's whether we were dealing with diabetes, macular degeneration, or vein occlusions. So it began to ask the question, is aiming to eliminate all retinal fluid with anti-VEGF therapy actually necessary? Well, certainly over the course of the years, we've learned that the fluid compartments matter. And specifically, our general knowledge now is that the presence of intraretinal fluid, which was very nicely alluded to earlier this morning, is typically associated with worse visual acuity, whereas subretinal fluid is at worst neutral and perhaps even contributory to better visual acuity over time. And then finally, and I mentioned this earlier on this morning, that RPE fluid generally doesn't really make a difference one way or the other unless it's associated with overlying subretinal or intraretinal fluid. So some of the first hints that drying the retina completely was not necessary began to come out of some of the earlier studies, such as the VIEW trial. And if you look at the left, you see that whether the eyes in the VIEW trial were persistently dry or not persistently dry, the visual acuity really didn't matter at the end of 24 weeks. And the mean best corrected visual acuity in patients really didn't depend very much on the overall fluid status. This was taken one step further in a post-hoc analysis of the Harbor trial of the 2 doses of ranibizumab when given PRN or given monthly. And there were some very remarkable findings that came out of the analysis. On the left, you see that patients with intraretinal fluid, whether you look at month 12 or month 24, had best corrected visual acuity gains that were below average. If you look at the right-hand side, you see that patients with subretinal fluid, again at month 12 or 24, had visual acuity gains on average that were better than average, certainly pointing out a significant difference in the effects of intraretinal versus subretinal fluid. And even more remarkable, it didn't really matter how much subretinal fluid was present. Whether we're looking at none or greater than 100 microns, the visual acuity changes did not seem to depend on the thickness in subretinal fluid in the Harbor trial. Well, people have then gone back and looked at some of our larger prospective randomized trials, and we see this theme occurring over and over again. In the VIEW trials, that the presence of intraretinal fluid was associated with worse visual acuity, whereas the presence of subretinal fluid was associated with better visual acuity. CAT showed us exactly the same thing, and this was done now through 5 years. So we have this very strong correlation between poorer vision with intraretinal fluid and better vision with subretinal fluid. Well, there have been some prospective studies that have looked at tolerating fluid with respect to then making decisions in terms of further treatment, either on a PRN or a treat and extend basis. The Altair trial was a phase 4 aflibercept trial, and they tolerated increases in central retinal fluid of up to 100 microns in terms of maintaining vision. And what they found was exactly the same as the previous trials. The intraretinal fluid seemed to make vision worse. The subretinal fluid, in this case, didn't seem to make a big difference over time. The Aries trial, another phase 4 treat and extend, was just a little bit different. And what they did was they said if there's subretinal fluid less than 50 microns in thickness, they'll actually use that for an extension criterion. So they tolerated subretinal fluid. And extended with it. And sure enough, in the ARIES trial, the persistence of subretinal fluid actually made for better visual acuity in the long run. And of course, the intraretinal fluid is as we had seen before. And finally, the fluid trial, this came out of Australia, looked at whether or not to treat aggressively or whether or not to tolerate subretinal fluid of less than 200 microns in thickness. And at the end of 12 and 24 months, whether you look at mean changes in visual acuity on the left-hand side, or whether you look at patients gaining at least 15 letters on the right-hand side, whether patients whether they tolerated the subretinal fluid or whether they treated aggressively, meaning they treated monthly if the fluid persisted, it did not make a difference in the final visual acuity gains. So it suggests to us that subretinal fluid can be tolerated and probably does not adversely affect vision. Well, what about intraretinal fluid? Does this apply across the board? So here's actually a DME trial. These are Yosemite and Rhine, the phase 3 trials with faricimab. And we see that the visual acuity results with faricimab are comparable to aflibercept. We see that the retinal thickness is actually a little bit better with faricimab. But what we found was there was actually more intraretinal fluid in the aflibercept arms than there was in the faricimab-treated arms when you look at treatment up through week 56, suggesting that intraretinal fluid in diabetes is not the same as intraretinal fluid in macular degeneration. So there seems to be something different. And it may not be necessarily the fluid itself that's the problem. It may be that the fluid is a biomarker of something else. So my colleagues and I did a systematic review a couple of years ago, and we looked at the literature of those trials that published results correlating intraretinal fluid and subretinal fluid with visual acuities. And for studies that showed results through 1 year, every study that described intraretinal fluid showed a negative correlation with visual acuity. When you look at subretinal fluid, however, it was mixed. Half of the studies showed that it didn't seem to matter in terms of visual acuity. Half of the results were associated with improved visual acuity. When we looked at 2 years, fewer studies, but essentially the same results. Intraretinal fluid uniformly negative. Subretinal fluid was a mixed bag of no effect versus a positive effect. So if we summarize that, we find that intraretinal fluid, without a doubt, has a detrimental effect on visual acuity. Subretinal fluid may be at worst neutral, at best protective at visual acuity results. So why might this be the case? So you heard me earlier talk about Starling's law. And Starling's law really is based upon where does the albumin go. And albumin, I think, is the key to describing the results that I've just mentioned with regard to fluid compartments. Albumin does not necessarily diffuse easily throughout the retina because the retina does have diffusion limits. This was a study back in 2003 by Jackson et al. And what they showed was that the retina is somewhat impermeable to macromolecules, and it's based on size. They suggested there was an inner retinal exclusion limit of about 76 kilodaltons. Now, that's not exactly correct, because we know that antibodies do penetrate back into the subretinal space. But what it does suggest is that larger molecules may not penetrate through the retina as easily as smaller molecules, and certainly not like fluid itself. Does intraretinal fluid in AMD originate from the capillary system in the retina, or is it from the CNV? Well, the reality is we're not really sure, but you can certainly be sure that where the CNV is very likely the contributory factor to where the albumin is coming from and where ultimately the fluid is going to and accumulates. So what are the barriers to albumin movement within the retina? Well, our standard, of course, is what we commonly think of as the blood-retinal barrier. The tight junctions between capillary endothelial cells, the junctions between RPE cells. But there is a third component here, and that's the external limiting membrane. Remember, the external limiting membrane is the footplates of Mueller cells interdigitating with photoreceptors. And it is a semi-permeable to impermeable barrier to albumin movement. So what I propose is that subretinal fluid is actually somewhat protective because it bathes the photoreceptors, provides oxygenation, and maybe even nutrients. But that intraretinal fluid may actually be a biomarker for the integrity or lack of integrity of the external limiting membrane. And various authors such as Schmitherfert and Jaffe have also reiterated that protective effect of the subretinal fluid. And furthermore, we see that the ellipsoid zone integrity was actually correlated positively with subretinal fluid, and so that the subretinal fluid seems to have a positive effect on photoreceptor sustenance. So with intraretinal fluid, though, you've got to differentiate between chronic and acute. Chronic is that exists over time. It doesn't go away with treatment. It has an irregular shape rather than that round cystoid shape that we typically associate with macular degeneration, acute leakage. But what about intraretinal fluid? There are, of course, tight junctions at the endothelial cells and the RPE, but there are also the same sort of tight junctions that exist at the external limiting membrane. And the proteins there, the occludin, the junctional adherent molecule, cadherin, and the other molecules actually exist in the same way between the foot plates of Mueller cells and the photoreceptors, suggesting that this may well be sensitive to VEGF, because it's those molecules and the phosphorylation of the molecules that breaks down the blood-retinal barrier. And so that I would propose that the external limiting membrane is actually the major determinant for the formation of intraretinal fluid. Now, I think type 3 AMD, as we'll talk about a little later tomorrow, might be the exception to this, but for types 1 and type 2, it's the integrity of the external limiting membrane and its ability to either keep albumin in the subretinal space or allow it to go to the inner retina is the major determinant of visual acuity in these eyes. And so in summary, subretinal fluid is associated with generally an intact external limiting membrane. It serves as a barrier to fluid migration, and it indicates healthier photoreceptors. Intraretinal fluid is the opposite. Cellular degeneration, which is chronic, or a breakdown of the external limiting membrane, allowing albumin to diffuse from the choroidal and neovascular membranes through the subretinal space and into the inner retina. So thank you.
Thank you very much. So I'll just summarize Dr. Stewart's talk. Thank you for showing us a lot of level 1 evidence for use of various anti-VEGF treatment protocols for neovascular AMD. We also learned a lot about the relevance of intraretinal and subretinal fluid, and especially how you should differentiate this from AMD and DME. The fluid compartments in both are quite different from each other. And I think one important point that we can discuss more is in patients where you have established treatment, established patients in your clinic, at what level will you consider extension of treatment? What is the level of increase in central macular thickness that you would consider to extend? So with this, I'd like to invite discussions, and Dr. Jai already has a question.
Excellent talk, Dr. Stewart. So I have a patient who I have been treating, she's 2020, I have been treating for wet macular degeneration. I have ruled out PCV for last 2.5 years. She has fluid, she responded really well with Eylea, then she had some fluid. I observed the minimal fluid. The unique part with that case is that her vision always remains 20/20, but she comes back with increase in symptoms. So my question is, and I am at the verge of actually doing a volumetric analysis of her SRF and trying to correlate the volumetric change in SRF with her symptoms. So where do you place the symptoms of the patient? They remain 20/20, and as we all know, Snellen's chart is not the best way to evaluate our patients, but unfortunately we have very limited choices. But where do you keep patient symptoms while treating and observing the subretinal fluid?
So, as I said earlier today, treat the patient, not the OCT. And if you have a very observant and reliable patient, and that's what I'm gathering from what you're saying, you trust this woman and how she knows her eye and her vision, that if she has increasing symptoms despite 20/20 vision, and then I'm looking at that as activation of disease. I don't know if you want to use the term recurrence or activation, but you certainly have increased disease activity, and in those circumstances, I would probably use that as a sign to treat her.
And you treat the patient, but the fluid never goes back.
Right.
What about the symptoms?
Right, so I listen to the symptoms and I would treat with symptoms. Because she has persistent subretinal fluid, I would probably never look at discontinuing therapy with her. If she had increasing fluid, I would look at that as a sign of increasing disease activity. And even in the absence of symptoms, I would probably use increasing subretinal fluid despite 20/20 vision as a reason to retreat. So I'd retreat her based on symptoms. I'd retreat her based on increased subretinal fluid, even if her vision remains 20/20 in both circumstances.
Perfect.
I think that's very well articulated. Yes. You have a comment?
Thanks, Michael, for a great talk. I have two questions. One is, in your systematic review, you show that subretinal fluid was, in most studies, was associated with either better vision or neutral vision. My understanding is recently there was a post hoc analysis on Horgan Harrier, which showed the opposite, actually showed worse visions. I was just wondering whether there was anything about brolucizumab or the study design that might explain that. That's my first question. The second question is a bigger question, which is we associate, if we assume that subretinal fluid is associated with better vision, it seems that we make this presumption that that's a causal link, that the subretinal fluid leads to better vision. How do we know that it's not just the better vision was associated with subretinal fluid, and that if we treated that fluid, they couldn't have even got better visions?
So, good questions. The first one is no, I don't have an answer. Need to do a deeper dive to try to figure out why. The second one is, you're right, we don't know it's causal. And so causal suggests, and if we were to think it was causal, then we would say, well, let's titrate the subretinal fluid. Let's make sure it doesn't go away. And so we'll keep it there. And I don't think any of us behaves that way. You know, if subretinal fluid goes away, we probably think we're hitting a home run because we've really inactivated disease. And I think, quite frankly, we should. But I do think that tolerance is something that we can use to think that we can relatively safely treat this patient and extend and decrease the treatment intensity, knowing that subretinal fluid is not going to be a negative biomarker. So cause and effect, no, but tolerance of fluid and modifying your treatment strategy, I think that's where this comes into play so far.
So just to clarify from a clinical perspective, if you see a patient, you treat them maybe monthly, they have a little bit of subretinal fluid, that's the situation when you're prepared to extend as long as that fluid doesn't get worse?
Correct. Doesn't get worse, visual acuity remains the same, I'll be willing to extend them, but I'm really not willing to discontinue therapy. If a patient's completely dry and they've gone 16 weeks between injections, I may consider discontinuing therapy. If they have stable subretinal fluid and I've extended them, I still look at that as some sort of presumptive biomarker of disease activity, and I won't discontinue therapy in them.
Thanks.
Yes.
Can I ask a question? So does your tolerance of fluid imply that you see more patients to control if the fluid gets worse?
I'm sorry, Stella, rephrase that.
So when you say I can tolerate some fluid, so you can extend the treatment, but does it mean that you check up your patient, control your patient, visit your patient in between these other treatments, or no? So it increases your number of visits?
Right, so I'll do it on a treat and extend basis, just as I would if a patient were completely dry, we're treating and extend. We slowly do that. I won't see them between visits because I'm developing a degree of confidence that by extending them and 1 to 2 week adjustments, that they're probably not going to recur between injections. So I won't see them in between.
In between. So that is, let's say, usually a choice not at the beginning of the treatment.
Correct.
It is in the,
Yeah,
the longer follow-up.
It's a long, it's, you know, we never get to the point, we never start a therapy thinking, oh, this patient, we're going to go ahead and treat them and then follow their persistent subretinal fluid. That's never in our minds at the beginning. But it's only something we develop when we see that the subretinal fluid improves but never goes away. And then our mindset changes to tolerance, treat and extend, but not discontinuation.
Good. Okay. Is there time for another question? Or?
Just last two, please.
Just last, okay. So I was very curious about this theory about the intraretinal fluid in DME and AMD. So I'm not sure if I understood it very well, but do you say that ELM is, let's say, the major cause also for the intraretinal fluid in DME, or it is only in AMD?
No, I'm only saying AMD.
Only AMD.
Yeah, I think in DME, the vast majority of the fluid is retinal circulation derived. So that's an AMD theory. But that being said, anybody wants to do a very large analysis, has lots of patients, I'd love to look at correlations. Correlations between fluid presence, subretinal fluid, intraretinal fluid, and integrity of ELM. I think that would be a great paper with a lot of data.
Yes, last question.
It was a very nice talk, Dr. Stewart. I just wanted a comment since we are discussing so much about tolerating subretinal fluid. I think this is one situation where the OCTA would help, because when we are looking at fluid that's coming and going, not going away, most of the time it's a type 1 membrane. And if we see that the membrane is increasing in size, then probably our tolerance level will go down than if the membrane is remaining stationary.
Yeah, I think that's a very interesting question. This data that I showed you from the systematic analysis didn't include OCTA. So we don't have the answer to that with this. You raise a very intriguing question of, is that the first sign of a worsening of disease activity, and should that trigger our treatment? And the answer is, it's very reasonable to say that. You know, quite frankly, a lot of people don't like subretinal fluid at all. And if you see any sort of marker that suggests worsening disease activity, and OCTA analysis may be that first one, I don't think you can be faulted for going ahead and treating them at that point.
All right, great. Thank you so much, Dr. Stewart. That was amazing.